Hi, everyone. So thanks for joining our weekly webcast today. So today we're going to be going over compensation strategies for PIs and Sub-Is. I know on last week's web chat we talked about finding good physicians. And so today we're going to talk about once you've found those physicians, how do you pay them? How do you keep them engaged based on kind of some different successful strategies we've seen in different sites. So as I go through these different models, please feel free to ask any questions. Definitely want this to be interactive, so as you come up with questions, please feel free to ask them, and we'll try to answer them along the way. So there's three main physician payment options that I'm going to go into today. All three of them I've seen be very successful at different sites, depending on the type of site, the experience of the physician, the patient volume at each of the sites, but there's definitely pros and cons to each model. The first model that I'm going to go over is what we call the percentage model. So the percentage model is just that. So you bring a study in, and when you bring that study in, you agree that you're going to pay a set percentage of the study budget to the physician. So that may be 15%, 20%, 25%. We've seen kind of the range typically falling within that 15% to 22, 23% with physicians based on the relationship, based on the study, but that's what we typically see at sites. So what does that mean? That means that it doesn't matter what the budget is, you're going to pay that physician that set percentage of that budget. So what are the pros to that? So of course, your PI cost is always going to be proportionate to the study revenue. So when it comes to accounting, tracking, projecting your expenses, that's going to be much simpler to do. Also in sharing with the physician what they're going to make, if you know how many studies that they're going to be working on, or if you have a projection based on historical data for the number of studies that you're going to be working on, what those budgets look like. Obviously, we know that site revenue goes up and down, and it's really hard to project. But it gives the physician a good idea of what they're going to be making on each study. Now, what's the drawback to that? As we know, there are some physicians that we all work with at sites that are very involved, want to be a part of every part of the research study, so excited about seeing the patients and conducting as many procedures as they can, in there with the coordinator as much as possible. Then there's other sites where the physician doesn't want to be as involved. They're not, with the patients as much as, say, the coordinators are, and, they're not doing any procedures outside of those procedures that are required, for the physician to perform. So in those cases, the payments may be in excess of what the physician is actually performing. So let's say that the physician is not very involved, but they're still getting 20% of the budget. Based on the procedural breakdown of the budget, if they're not actually doing 20% of the work, the site, you guys at sites are essentially losing a little bit of money when it comes to, paying that physician. It also, is tough to really, from an accounting perspective, track the value of every procedure that you're working on. To give you a little bit of background on that, when we negotiate our budgets for our sites, what we do is we break out each protocol on a procedural basis. When we do that, we actually, take each procedure, each process for the study, whether it's something like, a large item like a scale or a diagnostic test, all the way down to, signing informed consent or, taking a medical history. All of those different pieces are parsed out, and we assign essentially a different value to each procedure, which allows us to do well with our accounting and allows us to keep organized with our accounting. So when you do everything based on a percentage model, again, you have that disconnect between what the physician is actually potentially doing and the actual procedures. Because when we're budgeting out for a study, we say, okay, what staff members are going to be involved in that procedure or in that process? How much time does it take? And if you're going off of a flat percentage, some of those items may not necessarily match up, since we may not know exactly ahead of time, all of those different factors. And again, you may end up losing money based on some of those different pieces. So any questions on kind of the percentage-based model, please send them in. Be happy to answer any of those. Definitely have a discussion there. We find this is good for smaller sites. So those small sites where, again, that physician is heavily involved, where we see that the volume is not as high, and also it keeps the physicians engaged. And that they always feel that they're going to be receiving something from participating with you guys on the study. Another model that we typically look at is our per procedure model. And I really like this one because, kind of speaking about physician engagement, the physician is essentially tied into the actual procedures that they are performing. So what I mean by that is, going back to that budget breakdown that I mentioned before, when we see, when we break out a budget, we'll break out again by every process and procedure. But we would, in this scenario, in this model, we would only pay the physician based on the actual procedures performed. So why is this good? This is definitely keeping your physician engaged, because if they're not engaged and they're not performing these procedures, then they're not getting paid. So this is a way to, allow you to, make sure that the physician is, working on this study, on as much of this study as possible, and stays involved with the patients in all of the visits. This is also great for sub-investigators, and a lot of times, I know that Christian hit on this a little bit last week, and how you bring an investigator on, different strategies to getting a sub-investigator invested. But it's good for sub-investigators because a lot of times what I see with sites is they'll contract out with somebody, and they have a hard time kind of keeping them on or keeping them interested, keeping them essentially a part of a site, especially if the sub-I is not full-time. If they're contracted out, from another practice or another research site, based on the needs of the primary site. But if you're paying the sub-investigator based on procedure, based on the actual procedures that are being conducted, that will allow you to do well with keeping that sub-investigator engaged, because they're going to want to obviously help with those procedures and be a part of the study so that they get paid. Ultimately, that's also helping you as a site, because as the sub-investigator is more and more involved, they're going to get more and more a part of the site, ultimately become another resource that you have as a site in order to take on more studies and kind of everything that Christian talked about last week. Obviously, what's the drawback to this type of a model? It's definitely more complicated and more time-consuming from an accounting perspective. So unlike the percentage model where it's, I'm making $100,000 on this study, 20% of it goes to my PI, and that's that. And it's easy to track that. You can track that in Excel. Very, very easy. With this, you really want to make sure you're tracking procedure by procedure by procedure to make sure that your books are correct. And, it is definitely a little bit more time consuming. But on the flip side, you definitely, know what your PI is bringing to the table, and you're not throwing out money for, work that the PI is not doing. The PI, you're paying it for exactly what they're doing. Again, this is something that we find, just like the percentage model, we see with a lot of smaller sites, sites that potentially contract out with multiple PIs in the community. We see that, for these sites where, a PI may be involved in one study here, one study there, based on different relationships and different study needs, we see that this model typically is a good model to to take a look at. What we want to make sure, of course, up front is that in this type of a model, and in most of these types of contracts, the PI is clear up front as far as what what they're going to be responsible for and what the payment for those procedures is going to be. If any of you guys would like to see, we do have sample templates as far as those kind of study contracts for the investigators. So looking at what procedures the PI would be expected to perform, what payment they would get for each of those procedures, and the language that we put together with that. So if anybody would like to see that afterwards, definitely feel free to contact me, and I'd be happy to share that resource. Any questions so far as the percentage model and the per procedure model, and any kind of clarifications? How many of you guys work based off of a percentage model now? And I know that you guys can go in and raise your hand. So I want to see how many of you guys use that now. Okay, couple people. How many of you guys use a per procedure model? You should be able to go and raise your hands there. Okay. All right, I see a couple of you guys use that type of a model. Okay. But I saw that there were a few of you guys that don't use that type of a model, and I'm not sure if you guys, what kind of models you guys do use. I know there's a variety of other things even outside what we're talking about here today. The third model that I want to go over is probably the simplest to understand, and that would be a fixed salary or hourly rate for the investigator. Now, when is it, at what point are you, doing, say, a per procedure model, and you're contracting out with this PI over and over and over again? They're working on several different procedures. They're on site, 35, 40 hours a week, seeing all the patients. The patient volume is increasing. The study volume is increasing. At what point is it time to say, okay, it's time to put this person on salary? So, as you guys may expect, we see this with a lot of larger sites. Typically, we see somewhere in the 30-plus patients seen per week is when we see this type of a model typically become more cost-effective for the site. And what the great thing about this model, unlike the other models, and kind of what we talked about before, is you don't necessarily have to share study budget or the study budget with the investigator if they're on a salary. When they're on a salary, or when they're not on a salary, and you share the study budget based on the procedures that they'd be responsible for, you may have some investigators, and we've seen this at sites before, where they'll say, well, wait a second, why are you making as a site $15,000 per patient on this when I'm only making $1,500 or $2,000 based on what you have allocated to me? I can do that medical history. I can do that. We've seen that at sites, and even though we know that coordinators handle a lot of those aspects, and you need the physician for certain aspects, that's a comment that we see with some physicians at sites. So with this salary model, you don't have to share the study budget. You don't have to worry about them seeing what you guys are making at site. The problem, of course, with this model, as you guys might expect, is that it assumes that you guys will will have a higher risk. Let's say that, as a site, you guys are busy. You're running 25 studies, bringing in 50 patients a week, 10 different coordinators, you've got PIs, everything's moving smoothly, and then let's say that next year you have a tough year. The studies aren't coming in, the revenue is going down. At that point, you still have that PI on salary, and that $200,000, $250,000 salary, becomes tough to continue to maintain when you don't have the study volume. So that's one risk when looking at this, which is why kind of smaller sites where you're still kind of that variable revenue and you're still seeing kind of, large swings in your year-to-year revenue, that's when you probably are not looking at this type of salary. Of course, this is going to definitely keep, hopefully, keep the physician to be a part of the site. But one con with this is it may be tough to keep the physician engaged if they are a little checked out. And so this is going to be a little bit dependent on the physician themselves. So if we see that, the physician is, very excited and, motivated to come into work and, see all the patients and take part in as many procedures as possible, this might be a good model to take a look at. If we see that the physician is, kind of losing engagement, and kind of coming in, essentially what I would say, coming in and signing the papers, going and signing off, not really spending the time with the patients that, we would like to see. It's tough to necessarily keep them engaged when essentially they're getting paid regardless, based on, kind of the salary type of model. Hourly rates for PIs, if you're looking at this and you want to pay them by the hour, we've seen anywhere from $100 an hour to upwards of $250 an hour, commensurate, of course, on PI experience, the study, the volume of patients, so it can vary based on the type of site you are, the kind of the depth of the protocols. Obviously a CNS site where you're doing very involved rating scales and maybe lumbar punctures and and long procedures, long visits, long screens. I would expect the volume of work to be higher than, of course, some indications where you may not see that same type of patient volume as well. Some of those studies may be bigger, a lot of patients, a lot of going back and forth with new patients. Other studies, if you're doing a tough GI study, and there's 2 patients that you recruited in a year, those are the only types of studies that you have. Obviously, that's going to be a different conversation. So, again, if anybody has any questions or specific situations, definitely happy to discuss that in detail as well. So one thing across all models that I do want to kind of touch on at the end here is for any of these contracts, one of the most important things that you can put in place with your physician is a non-competition agreement. So whether you're paying them by procedure, paying them by percentage, or on a salary, you want to make sure you put some kind of a non-competition agreement in place. The reason you want to do that is because we've seen this happen. We've seen the negative consequences of not putting a non-competition agreement in place where, if, let's say, to give you an example, and there's many examples I can give, of situations where this has come up, but to give you an example of something that we saw, in the last year or so at a site, working with a site, and they were, they were busy, and then they got, a little bit slower. And the investigator got a little bit restless, and they thought, I want more studies, I want to be involved, I want to do more research. So then they started going to other research sites and offering their expertise. So what ends up happening is the physician says, I actually like site number 2 a little bit better. And so then what they end up doing is in site number 1, let's say they get a really good study and that physician is excited, but they started to pull out of site number 1. We've seen that be that situation. I'm sure a couple of you guys on the line have heard of these situations, or maybe, and I hope not, but maybe you've kind of gone through this situation where the physician may end up taking the study to site number 2. And if there's no non-competition agreement in place, that's tough to, that's tough to fight legally. And so it's very important, even if you have the best relationship with your physician, things can always happen, to get some kind of a non-competition agreement in place. And we do have language that we can share with you guys as well. If there's anything that you guys have questions on as far as how to have those conversations, how to frame that so as you're not discouraging to the investigator, that's something that we can, definitely share with you guys, and we can talk about, more offline. And even, setting up these contracts. I know we've worked with sites in the past where they've brought on a new physician, and they've come to us and said, hey, we're working with Dr. So-and-so. This is going to be the first time we're going to be working with them. Do you have a contract that you can put in place, based on maybe it's the percentage model or the procedural model, that we can, put together in order to get that physician on board, and that's something that we can help with as well. So I hope that was helpful. So my direct email is Scott, SCOTT@btcsites.com. So again, if anybody has any questions, let me know. And so what I'll do is I'll answer a couple of the questions that are coming in now, but if anybody wants to take anything offline or kind of talk to us further about how we may be able to help in your specific situation, definitely let me know. So this question that just came in, when using the percentage method, if you guarantee the PI at percentage, how do you pay the sub-I so you do not go over the predetermined percentage amount? So it's a good question, and again, one of those drawbacks to the percentage model. So it sounds like the question is that if you're guaranteeing the PI percentage, let's say you're guaranteeing them 20%, and then you want to also pay the sub-investigator, that's when it becomes tough. So I assume that based on this question, you're saying that the sub-investigator would be paid based on a procedural model, and so based on the procedures that the sub-I takes into account, that they would be paid for those procedures. And you would want to make sure that you're not going over, if you're already guaranteeing the PI 20%, that now you're cutting into some of your other, your other deliverables, your other revenue sources from the study. So it's a good question, and unfortunately, I would say that is definitely a drawback to the percentage model, because again, if that PI is not, conducting all of the procedures that would make up to that 20%, you are going to end up going over. Now, one workaround we have for this, and we actually work with a site where we do something like this, is when we go through the budget and we negotiate the budget, the site actually has asked us to go through and actually, when we're breaking out the procedures, instead of just pricing at each procedure individually as we typically do, we look and see, okay, the PI is going to be involved in this, and this. So when we're negotiating each budget, we make sure that that total PI fee adds up to what that percentage is. So if the PI is supposed to make 18% of the study, we make sure that those procedures add up to just 18%. And we make sure that that sticks across all studies. So in the event that there is a sub-investigator that has to take on procedures that the PI cannot do or that the PI is unable to do, that way we're covered in that, the PI does what was allocated to that PI, and then the sub-investigator procedures are separate from that and not part of that percentage. So we're not, getting to the point where the PI is doing 8% of the work and getting 18% of the payment and then paying a sub-investigator on top of that. So that's one workaround that we have with that, but it is definitely a good question, and it's tough to necessarily deal with that when you are in that type of situation and you're paying the investigator on a percentage but not reflecting that in your initial negotiation. So awesome. If you guys have any other questions, I'm happy to answer them. Otherwise, as I said, my email is scott@btcsites.com. And we look forward to continuing these webcasts, and we'll be back next week with a new topic. So thanks, everybody.